One of the reasons that we created the Chief Quality Officer program in the first place is there was no theory. Everybody I interviewed, I'd say, well, what's your theory about how to do it? And it was all kind of like, nobody's ever asked me that. Well, let me tell you what I do. So part of what I did is developed a theory and created a driver diagram. And a lot of it was rooted in what IHI was doing at the time. But there's a need for organizations to have a theory about how do they approach quality as a structure and across the system.
Welcome to Leading Quality, the podcast spotlighting the people moving healthcare forward from the front lines to the C-suite. I'm your host, Jason Meadows. My guest today is Dr. David Williams. David has spent decades working at the intersection of improvement science, leadership, and systems thinking, helping organizations move beyond isolated improvement projects to something much more powerful, building systems that are designed to learn and improve. His path into this work actually began on the front lines. Early in his career, he worked as a paramedic and later as a chief quality officer for a large metropolitan ambulance service, where he began to see a pattern that many of us in improvement eventually encounter. When something went wrong, the instinct was to investigate the individual. But when he looked closely, he discovered something deeper. The people involved were often just, as David puts it, the improvement canaries, revealing problems in systems that were never designed to reliably produce the outcomes we expected. That realization led him to a lifelong focus on how we design systems that actually work for most people most of the time. Over the past 2 decades, David has been deeply involved with the Institute for Healthcare Improvement, serving as a senior lead for improvement science and methods, and helping shape how improvement capability is built across organizations. He has worked with health systems, educators, and leaders across multiple industries applying improvement science to complex systems. More recently, he co-authored the book Quality as an Organizational Strategy, along with Lloyd Provost and Cliff Norman. The work builds on ideas from Deming and the science of improvement to explore a central question for healthcare leaders. What would it look like if quality wasn't just a department or a set of projects, but the core strategy that guides how an entire organization learns, improves, and delivers care? That is the question we explore in today's conversation. David, welcome to the podcast.
Thanks for having me, Jason.
Yeah. And as we said, we'll go with first names for today's discussion, if that works for you. I just wanted to get a bit of an intro to you and your career. You've spent years working for the Institute for Healthcare Improvement and thinking deeply about healthcare systems. And I'm curious kind of what first brought you into this improvement work.
By background, originally when I was in school, when I graduated from high school and college, I was studying emergency medicine. And I was involved in pre-hospital medicine. So I went to college for ambulance system design and ambulance management, and I worked as a paramedic for a number of years in cities in the States. And then my first leadership role actually was to be the chief quality officer for a large metropolitan ambulance service. And part of the reason that I ended up in this role was that I was doing a graduate program in the management of ambulance systems, and I took a course that was related to quality that was being taught by folks that had been similar to how folks in healthcare had been trying to bring quality into industry. There was folks that were trying to bring it into the pre-hospital space, and I studied quality and ended up in this role initially. And then I worked in ambulance system consulting and quality for a number of years. And that's how I crossed over into healthcare. My colleagues from Associates in Process Improvement, who were really fundamental to developing the methods and early work at IHI, were from Austin, where I live. And they invited me to come and be an improvement advisor on projects at IHI. And that was about 17 years ago. So I've been collaborating. IHI has been one of my clients for about 17 years. I spent about 5 years on the leadership team there as the senior lead of improvement science and methods and leadership. And then I've been a faculty member with IHI, I think, for about 6 or 7 years since I left.
Yeah, and you mentioned having been a chief quality officer for an ambulance emergency management system. You said, first of all, when was that role, and what was that like? Because I can imagine your career has followed a kind of a progression towards from more frontline stuff to more quality as an organizational strategy, which we'll talk a lot about as we go. But I'm curious what that job was like, and then maybe we'll contrast that with how your thinking has evolved over time.
Yeah, so my role as a chief quality officer was 26 years ago, and I was in it for about 4 years. At that time, it was still a heavy focus on individual error and sort of investigating root causes. So a big chunk of my work at that time was in that space where either we would identify, our office would identify, or people would self-report that there had been some kind of deviation from practice or some kind of mistake that occurred, and then my department at the time was really focused on, they called it kinder and gentler, but really it was investigating these events and trying to do a blend of employee education with, I call it an illusion of improvement, but there was a sense that we were looking for ways that we could fix the system, but there was always a theory that the system was actually kind of okay, and that just people forgot things or deviated or did stuff. But at that time, one of the things that was sort of a revelation for me was that almost any time that I looked at anything that was reported, if I, pulled a sample of cases, I would find, 20 or 30 instances that weren't reported, that people didn't even know where something similar had happened. So over and over again, I was realizing that the system was not built or not fit for purpose, as John used to say. And so it was these people were just the what I call the improvement canaries. Like, they were telling me about things that were happening in the system, and they were just the unfortunate person that happened to be either identified as making the mistake or raised their hand and said, "I think I missed something," and they were just really telling me that the system needed to be fixed.
Yeah, I think the tip of the iceberg is something that that a lot of people in this field could relate to. Seeing, the case that gets reported is only one of many. How did you come to actually find that out? That's interesting that you were able to discover all of these underlying cases.
There are a couple of different places. I mean, it was, when I started the role, it was already in this position that it was about looking at individual errors. So that was kind of the job that I entered. But over the course of my early career in quality, there were a number of different events that started small, and then when I pulled the thread, created bigger learnings about the system. So, I mean, two in particular ones that really stand out is in the 90s, there was a movement in emergency medicine for years. If somebody was, fell off a roof, or if they were in a car accident and their car rolled or something like that, the common practice at that time was to assume that they had some kind of spinal cord injury. And so, in the pre-hospital environment, what they would do is they would gingerly move people onto these long, oftentimes just wooden boards. They innovated to plastic, but they were, these hard, rigid boards. And then they would strap them down on these boards to hold them secure. And once that happened, you might be on that board for, an hour or more, while you were transported to the emergency department, while you were evaluated for the emergency department, while the emergency department took you to the to have imaging, only to rule out that there was such a small number that actually had an injury. And sadly, in this time frame, then you're also uncomfortable. You generate pain. You potentially have a risk for pressure ulcers. There's all kinds of things that were going on. So there was a big study in the 90s that looked at the potential to be able to use some criteria to be able to figure out who should be evaluated or not, who's at risk. It's called the Nexus study. And so we were trying to figure out how to do that in the field, the pre-hospital environment with paramedics, because if we could do that, we could dramatically reduce if we could assess people around these evidence-based criteria, we could dramatically reduce the number of people that got put on these longboards. And then that, from a patient experience standpoint, they would just all the way down the pathway would be having a better experience, lower cost, lots of less issues. And so anyway, we implemented a protocol and training program to do that. And just right afterwards, we just continually were having issues. Errors were being reported. People were saying that, folks were following the guideline, doing all this stuff. And it was fascinating because it was one of the hardest protocols that we had ever tried to introduce or changes to care. We had done multiple training programs. We had tried it in different vehicles. We had, different avenues for doing it. And what I discovered when I got into it, and especially when I started to pull records of these errors, is that, I was getting 1 or 2 or 3 reported every day, but I could pull 20 and, 20 cases, and almost all of them had some issue. So it was obvious that this was not working as we had designed it. And it was obvious that the people that were trying to assess and take care of patients were trying to do their best and didn't know what they were doing wrong. And actually, I'm not really sure that they were truly doing anything wrong. And it was a system issue. So, I mean, that was one of the first ones where every time I pulled a sample, I would find errors that were exponentially more errors, I say, in terms of a perception that things deviated from the standard we thought mattered. And the reality was just that we didn't have a system that could produce good results. And so that was a huge learning. I did another similar project that was related to medication administration and narcotic administration and actually it was really around storage of all things, of proper storage and sort of custody of narcotics, because paramedics carry them. So unlike in a hospital where there's you go to a very locked box on the side and you have to enter in codes and there's all kinds of safety things. In some places, people physically carry them on their body. Sometimes they're carried in a bag or they're in some kind of locked cabinet, and there has to be a transfer of custody from, shift to shift. And so there was a custody transfer issue that when I, went to investigate this individual case, which were around individual providers that were actually at risk of losing their position, I unpacked just system issues left and right of all kinds of stuff. And so every time one of these things happened, I would discover, if I looked, I would discover that the system was never built to produce the results that we wanted. And so that theme emerged over and over again. And I wanted to figure out how do I improve systems that get good results versus try to investigate people that are that 5% that create errors and have issues.
You describe again this early role where it was very heavily project-based and an individual review-based, kind of starts to feel like this initiative treadmill or, projectitis, as I've heard some people refer to it. When was it that you kind of started to realize over the course of your career that there was something that needed at a higher level, that you needed to be able to zoom out and change the structure rather than focusing on individual projects?
So it was a couple of things. So actually, I will push back a little bit in the fact that almost all improvement happens in the context of projects. And so that's actually useful. I think what you're describing that's a challenge is that very frequently, like in my early experience, projects were they were episodic and emerged out of perceived events, not necessarily, so they were reactionary versus strategic. A lot of the fatigue that you're describing that I see quite a bit is absolutely right, that people generate portfolios of efforts or initiatives of which are desired to be pursued, and they may not have been chosen based on looking at the system that you have and figuring out, are these the most important, impactful things that we should be working on? And then how did we evaluate it in order to be able to figure out what to do and what needs to get done? And so I find today, I think that's one of the things that it was sort of groundbreaking for me, and a lot came from my early work with my mentors at Associates in Process Improvement, was this sort of shift of looking at and sort of investigating root cause to flipping and saying, well, I want to figure out how to create the system that gets the results that I want. And then if there's a gap between the system I have and the system that I want, then I need to work on that journey. How do I go from the system of today to the system that I should have, so that I create a system that I like to say, works for most people most of the time in human systems. So it's not perfect. It's not, we're not manufacturing where we can dial things down into very, very tight numbers. But in human systems, that's my main goal. I'm trying to get it to work for most people most of the time. And that's where the shift really, flipped for me, is to say, what we're trying to do is build a theory about what that system is, use techniques to understand the system that we have, and then also to try to test and adapt that system and see if what we're doing results in improvement. And that shift started, probably 20 years ago, and has been, what most of my time has been focused on, either at the project level, like in terms of initiatives where people were working on breakthrough series collaboratives and, very focused on specific things like infection rates, or trying to impact cost and quality, or working on behavioral health, or various things like that, and a lot of work in children's spaces, to starting to say, like, well, okay, great. How do we change organizations, and how do we, do quality across the whole organization?
Yeah, and I appreciate the clarification there, of the importance of the frontline projects, and that how that persists, but that there's also this need for structural change at a broader level. I'm assuming that when you say a 20-year timeline, probably a lot of that was during your time working with the IHI, and were there other positions that you held, or was the IHI kind of your primary customer for a lot of that time?
So for the last 17 years, IHI, at least for 12 of those, has been one of my customers. And then, for 4 or 5, I was on the leadership team. When I wasn't working full time at IHI, I always had a portfolio of other clients that were working in improvement in quality, in health systems and education, and still sometimes in my roots with ambulance service. One of the things that I have always been interested in. So while there's a common theme of healthcare in my background, that I've always sort of had that thread. I've also been curious about being able to do improvement in different disciplines. So, I spent a good chunk of time working in the education field when education was trying to learn from what healthcare was doing and apply improvement science to improve the outcomes in education. And I did some work helping the Carnegie Foundation for the Advancement of Teaching when they started to really take that on as their mission and purpose. Worked with the Bill and Melinda Gates Foundation in that regard. So I did a little bit in that space. I've always had a parallel where I've done a little bit, maybe a project a year in the ambulance service space. And then I've had the pleasure of working in other spaces that are totally unrelated. I worked at roofing companies and other kinds of companies, and anywhere where there's process improvement can be applied.
Yeah, and I'd like to maybe take that opportunity to kind of move into, I think, what will be the bulk of our discussion today, which is your work in quality as an organizational strategy. And so you co-authored a book by the same title, as well as the QoS Field Guide. And I'm wondering if you can kind of just walk me through and walk our listeners through what quality as an organizational strategy means as a term, and what that means in practical terms.
Sure. Well, so in from a definition standpoint, organizations are all built for a purpose, right? That we are delivering services to people to match some need in the world of which they have, right? So in healthcare, it may be that people have need for testing, or they have need for preventative care, or they have need for very specific care. There's a need that exists, and each organization is aimed at trying to do that. As I've already sort of mentioned, as a kind of a theme about organizations, is that these organizations are all systems, of people and processes and services that are aimed at trying to provide things to match that need. And so part of what we need to be able to do is to figure out what is the system that best matches that need and can do it today and do it tomorrow and can do it to continue to get better. And in doing that, that means that we have to have some methods and ways in which we can learn both about how we're working, but also how we might need to change. And then we need an ability, and this goes back to improvement, to be able to pick the things that need to be changed and learn how to do results-driven improvement in a reliable way, and continue to get better at getting better. So that's the underlying bit of what quality kind of at an organization-wide perspective is. The book Quality as an Organizational Strategy actually has its roots back in some early work of Dr. Edwards Deming. I always like to point out there's an image. It's in his book Out of Crisis and also in his book The New Economics, but it dates back to the 50s, 1950s. And it looks like an arrow with some lines that come off of it, and it's Deming's what he called production viewed as a system, and in his book he describes that back in the 50s he was trying to explain actually to leaders in Japan, I think from the hotel industry, about how do you think about improvement at an organizational level. And so he points out back then that that there had been some great progress at project-based improvement. So people working on episodic things like we've been talking about, where people are trying to figure out how to fix this or fix that, that there had been like a level up that was starting to occur where people were starting to work on like major business processes and kind of get into bigger initiatives that weren't just these episodic little things, but were really something that was bigger and had more of an effect. But he argued that honestly, to go to the full potential of the science of improvement was to focus in on quality as your overarching strategy, and that was where all the opportunity was and where it really made a big impact. So he articulated this. I think the first published drawing was in 1950. There's a paper, and then he just kept repeating it. The iterations of it would show up in various writings all the way through his books. And in the 1980s, my colleagues at Associates in Process Improvement, so folks like Lloyd Provost and Cliff Norman and Ron Moen and those guys, were working with Deming when he was doing his 4-day workshops and talking about these ideas and trying to get leaders in industry and anywhere. I mean, people like Paul Batalden and Don Berwick to apply these theories and methods in the kinds of organizations that they were working in. And so the folks at API began to try to start to take his theory and put it into practice. And they started developing methods and strategies and actions that for leaders that were built on the 4 lenses of improvement science, but built on applying it at an organizational level. And this is what originally was called quality as a business strategy. It was used with clients in the 80s and 90s. And it was first published in the first edition of the Improvement Guide. In one of the chapters, there was actually the full method that is our book, and there was a case study of a school system right up the road from us, north of Austin. So anyway, this had been around for a while in terms of the ideas and some of the methods. Lloyd and Cliff, to some degree, were always using it in the background anytime that they worked with clients, but it took a little bit of a pause when there was such a growth of project-based improvement in healthcare and focusing in on things like projects with using the model for improvement or doing like collaborative style approaches like breakthrough series collaboratives and learning health networks. But right around the time of the pandemic, right around 2020, actually just before that, there were a couple of things that were happening in the world that prioritized us wanting to create a book. And so one, obviously, was that the world shut down, so it provided a little bit of free time. But also, I had just spent a number of years when I had been on staff. I just left IHI, I think in 2019, but I had spent a number of years there studying how quality worked across the system, working with different organizations to think about how to do improvement capability and quality across their system. IHI was beginning to articulate what they call whole system quality, which is kind of an adaptation of the Duran trilogy, and they were still in that process. I had just developed and run. I think it was two cycles of the Chief Quality Officer Professional Development Program. So for me, when there was a pause in 2020, I sat down with my colleagues, Cliff Norman and Lloyd Provost, and I said, I recognize that there's a need for people to be able to approach building a system of improvement across an entire organization. I think that the more that we can build on the shoulders of what we've already been teaching people about the system of profound knowledge and improvement science and the four lenses and these tools and methods, like building on the shoulders of that is the proper way to do it. And I was very familiar with the early work that they had established, and I said, I think that this work needs to be built upon and evolved and published, and especially before you all retire and it's we lose that sort of knowledge. And so we worked from 2020 through 2024 on writing the first book, Quality as an Organizational Strategy, which was a book that described the theory. We jokingly call it the airplane book because it would be the book that you would pick up in the airport and go, oh, this is really interesting. I want to learn about it. And then we followed that up this past year with the QoS Field Guide, which is an equally sized book, but a workbook that involves more detail about the theory, but also includes lots and lots of examples and exercises and methods and things to apply the theory. But that was the background that led up to it, is that we wanted that desire and wanted that ability. And I really perceived that there was a need, especially with my work with healthcare like leadership groups and chief quality officers, that people needed some approach to look at and focus on improving quality across the organization, not just having it be a department or projects, but actually be the way that we work, the way that we do things. And that's where QoS came from.
Yeah, and I can understand probably a lot of people listening are familiar with the quality department model of things. And it sounds like what you're proposing is a kind of in stark contrast to that, to have this way of working be the way we work in every aspect of our work. Who is the audience for this work, for this book? I wonder if you can speak to that.
The audience for quality as an organizational strategy are people that are in a leadership role, and mainly that is because leaders are the ones that are responsible and own the system that needs to be changed. So this is very much focused at the C-suite, at chief quality officers, chief operating officers, chief financial officers, whoever it is that wants to build the system and make it work so that it produces the results that you want, and wants to figure out how to continually learn and get better and create a learning organization and a results-driven improvement organization. So that's the target audience. It's different than, say, people that might be in a microsystem or at the point of where service is delivered and are changing the processes at the point of care. This is a book that's targeted at the leadership level. And that is a difference. That's a little bit unique, but that's the group. And, part of it, going back to the comment about quality, Jim Reinertson, who used to be one of the leadership faculty at IHI years ago, drew this great picture for me one time. And it was like a big circle that was your organization. And then in it, there was a little circle. And he said, that's quality problems. And he would describe that, in many organizations, there's this little circle of which there are what are defined as quality problems, of which we apply improvement science to, and we do project-based improvement to. And then he would say, well, what do you do? What's your theory about how you fix everything outside of the definition of quality problems, the rest of your organization? And what I find is that, the start of quality and improvement thinking in healthcare has called certain things improvement problems and certain things not, or certain things quality problems and certain things not. And you hear that all the time. People say, well, that's not a quality thing, or that's not, and my bias is that it's artificial to make that distinction. Deming never made that distinction. Nobody in industry never, they didn't make that distinction and say, well, something's a quality problem or something is a clinical problem or something. The organization is the thing you're trying to create, and it's made up of a bunch of process that has to work reliably to get the results that you want. Now, it's not unreasonable to have a dedicated person whose job is to be the steward and leader of quality in the organization. So having a chief quality officer or having a chief quality department is not an unreasonable thing. It's helpful to have somebody who might be helping with building capability or focusing in on certain things or helping to align. But the underlying theory should always be that our goal is that the whole organization operates well. Not just certain parts of it. And this is our theory about how we improve the whole organization, not just things that have been designated as in alignment with our definition of what is a quality issue.
Yeah, there's probably a lot of kind of distinctions without a difference when it comes to separating, quality problem versus not quality problem, as you're saying. I'm curious, and I do, I look forward to reading the book, though I haven't had a chance to read it yet. But I'm curious, when you zoom into governance, what is the role of the board in making quality real rather than symbolic?
Well, I think the board and the leadership team have a responsibility to ask, and I go back to, what's the purpose of this organization, right? So why are we here? What is the need in which we are driving to fulfill with our services? So when you're very, very clear about what the need is, your organization is trying to deliver services for, then the second question is, well, how do we build a system that delivers those services right to match the need for the patients or for our clients? And so having that laser focus is really important. Now, that then gets us down to saying we want to understand the system that we have to recognize why are these services the ones that we choose to focus in on? How is this system built to produce those services with reliability and effectiveness and meeting the things that matter to our patients and clients? And then how do we continually gain intelligence and learn and figure out how to get better and better at improving the system to keep matching the need or to change it if we need to, or change what we do. So the board for me should always be hyper focused on wanting to make sure that's where the attention is, and that the activities and the things that people and leaders are doing are in service of either understanding whether we're in alignment with the need or are trying to continually figure out where do I need to improve the system to get better at getting better in providing our services to the people that we serve.
Is in healthcare organizations, since you've had such a broad experience, is that laser focus on purpose and how we, our mission and how we deploy that mission, are they commonly laser focused on this? Is that an easy thing to orient people to?
Yes and no. So, I mean, I will say that in most organizations that I go into, healthcare organizations, there is a heavy focus on being purpose-driven. And people either will be purpose-driven in terms of, I really care about taking care of patients and I want to do evidence-based care and I want to do the right thing and I never want to harm them, right? And there are varying degrees in terms of where leadership or boards are driving with mission focus or not, or purpose focus. But I think it's always present. In every organization that I encounter, though, there's always a really good opportunity to revisit it and reflect on it. Because I think that sometimes it's, like with anything in the world, sometimes things get into a routine of saying them, but we don't actually pause and say, well, what does it mean to actually do that? And so it's part of it why we focus on it so much. That one of the first activities that when we start working with any health system focused on kind of moving from where they are to really trying to adopt quality as a strategy, there's really two things that we do together almost immediately, and one of them is to ratchet up your ability to do results-driven improvement work. Because if you can't figure out how to do improvement in a reliable and effective way, working on quality as a strategy is kind of a moot point. And then in parallel, we often start leadership teams by having them go back and really reevaluating and thinking about what's our purpose, what are the needs that we're trying to satisfy, what are the values that either we espouse, we say that we desire, or actually that the organization conveys back to us, that we see this in our people and in our culture. And then how do we actually describe that and put that into practice? So what does that look like? If I say that I'm team-based, how can I show that every time? If I say that I'm going to be patient-centered, it's one thing to say I want to be patient-centered. It's another. As you know, it's very, very hard, and it's a different thing to actually bring patients into every conversation or trying to get them involved in the way that you design or redesign the way that you deliver care. So that often is a big focus. I will tell you, many organizations will try to, I don't want to say deflect, but they'll try to say, oh, we're fine there, I don't want to work on that. And I've never found one that actually didn't benefit strongly from revisiting those two areas from the beginning. Figuring out whether they can actually efficiently do rigorous improvement, and looking at, are we clear on our purpose and the elements of our purpose, so that we can then refocus in on thinking about the system that achieves that purpose.
I'm also curious about, I could wrap my head around a lot of what you've said so far with respect to quality as an operational strategy, and how we allow the thinking around quality to permeate everything that we do, and have that aligned with our North Star. When you're looking at a new organization, are there structural signals that quality really is embedded into the strategy, or structural signals in the organization that tell you that quality is more peripheral?
Well, I mean, I think the way I look at it is that there are organizations that are on different places in their journey. There's things that I'm sort of watching for. So I'll give you a good example. Recently, I went into a health system. I delivered a keynote for their quality week, and I got to sit through and listen to reports about various improvement efforts that have been going on. They have an internal advanced training program, and so these were projects that had come out of that. And one of the things that was just so apparent right away was, a few things. One, I could see a shared method across all the projects. So even though I could maybe, I could critique the way in which the project was done, and I could kind of gauge the level of rigor that exists in their program. I saw the model for improvement in this case was used in every project. I saw a utilization of very similar tools to kind of break down what was going on, how things were going. I saw teams that were teams. It wasn't just an individual, and that they were learning from interacting with different folks that were involved in the microsystem where they were working. So to me, there was tons of, I call it the ingredients of goodness, right? So there's tons of stuff here that I can see that is obviously the result of them having focused on trying to build capability and try to create their own systems. And obviously the fact that I'm sitting in this room watching them on a broadcast, it was in person across multiple different cities because it's a big health system, and there's hundreds of people that are participating. There's some really strong evidence that this particular place is in the right direction. Now, also has a lot of opportunities to be able to take it to the next level. And I see that in a lot of the organizations I go into. This is probably the most common theme. When I started in quality 25 years ago, the model for improvement and project-based learning and all that stuff in some of the basic tools in healthcare was kind of novel. As a matter of fact, a big chunk of my early career in healthcare was going around and teaching improvement, the basics of improvement all over the place. And I mean, I did a ton of that, of which today I do almost none of that. But partially because a lot of the people that we taught 20 years ago are now in leadership roles or have created their own programs or teaching, which is fantastic. And it's such a good sign on building improvement capability. The thing that is not there yet is that there aren't as many that have gone from what I would call the foundational level to kind of an intermediate or advanced level of improvement. And that's much more episodic. And that's a lot of, like in this organization, that's where they have the huge opportunity to go, is from frontline foundational episodic improvement work to moving to more systematic and rigorous and spreadable improvement work. There's places to gain. Folks that aren't at that level that I see, and there are some organizations where I would call it kind of a potluck version of quality, which is where they've got some of the structures and maybe leadership, but they're outsourcing all of the activity. So maybe they hire people that have credentials, and then what you see is a mashup of different methods and credentials and experience. And so when you look at their work, you see those, that variation in methods, that variation in results, not a lot of systemization where everything is based on the individuals that were involved, not as a group. So it's really hard to scale. There's often a lot of friction trying to figure out what works or doesn't work. That typically is where, I'm always encouraging people, you got to pick something. You got to decide, what's my faith tradition of improvement? How are we going to figure out how to make that the way that we work together so we can communicate and reduce a lot of that friction to get better? Like the organization that I was recently visiting, they had made those choices. And so they were seeing a lot of those benefits of having a shared method and having an internal advanced training program that they were working on and having a structure that invited people to learn from each other. You want to get to that. And then from there, you want to build on it to try to get more systematic and more efficient at getting results.
Sounds very certainly relatable to my experience and probably to a lot of others. This the presence of frontline episodic quality improvement happening, and then not as many organizations having shifted to that kind of medium or advanced level of having more structural quality improvement. Have you seen organizations actually make that shift to seem to go from less just episodic quality improvement up to something that really, is genuinely more kind of structurally ingrained?
Yeah, I think I've seen it in a number of different organizations. Typically what ends up happening is that leadership, who has always been supportive of improvement in the way that it is, starts to recognize that they look at it and they go like, okay, here's the great things that I have. I've got, when I get people working on improvement projects, they get excited and fired up. They when they start doing stuff where they can actually test changes in their work environment, and they see either they are flooded with learning because they're altering the system, and that gives them feedback, or they actually see like movements of dots in the direction of goodness on their charts, and they see improvement. They get excited, like they recognize that potential. But what they often will see, this is a lot of leaders will recognize, is that these projects are struggling because they're in competition with the daily work. And to some degree, that is often because we didn't choose the projects that needed to get done. We chose ones around the periphery of the thing that mattered. And so, and we've even promoted that. We've said, oh gosh, tell us what you want to work on. Well, a lot of times when people say, I want to work on X, they don't pick the stuff that's right in front of them that's causing all the challenge, because they think, I'm not going to be able to change that. So I want to work on my project over here that I've always kind of been interested in and nobody's as interested in. And then that struggles because it competes with the actual work. So leaders start to recognize, I need to help. I need to figure out how we actually solve the core work together. I hear time and time again of people saying, I had this fabulous team. They worked on it for a really long time. They got to something, and either they stopped the project and they lost the results, which is a sign that they actually didn't finish the project. They didn't install it to the degree that it held, because they didn't change the system. Maybe they were kind of paying a lot of extra attention or measurement, or it worked in this one spot, and we can't scale it to anywhere else. We can't spread it in other places, and so that seems like a waste. And there's a lot of this conflicting comments around the burden of improvement, or it takes so much time, or the cost. All of those things I find are side effects of not having it embedded in doing the right work in the right way. So if you look at the work that you're supposed to be doing and you say, these are the things that are the core to our unit and that are not working in the way that we want them, and now let's do improvement work on that. Well, that's part of the daily work. It's already there. I don't have to make it. It is. So that's going to reduce the competition. And if I'm getting to make my work easier and with less friction, then that's going to make me happy and desirable. And I'm going to become an expert in my space, because I'm going to learn all the things that work and don't work. And so the next thing that leaders want to start doing is, how do I look across the organization and recognize there's a finite amount of time and attention and resource? Where am I going to get the biggest impact in the core to move our organization towards where we want to go? And I think that a lot of folks sort of conceptually get that. They struggle with, they don't have a method or an approach to be able to do that. And that's where I think there's been a lot of attention on this idea of quality across the system, and wanting to think about, like, how do we plan and decide on what's the right portfolio of projects? How do we resource that appropriately? And one thing I don't think is focused enough on is, how do we get better at doing improvement work? So my common experience when I look at people's work is they have projects that are all over the organization and many of them are taking way too long. And partially it's not because of lack of good people or wanting to do good work. It's just that people don't know how to do rigorous improvement, and so they're just working really, really hard to do the work that they have, and they're just inefficient at it sounds terrible, but they're not applying the methods in a way that they can learn quickly, make changes that get results, and then see those results in a timely fashion. And so projects tend to stretch and take longer, and they don't progress. You don't get to have as much impact as you could. And that's just it's like anything. It's like building up a discipline. If you've ever tried to run a marathon, for example, I don't know about you, I'm not a runner, but if I tried to run a marathon today, it'd probably take me 3 or 4 days to get across 26, miles, and I'd look really bad, right? But I bet I'm capable of it. But what I need is the discipline to figure out, well, how do I run a mile? And what are the things that help me be efficient? And how do I get better at that? And then once I do that, I bet I can get to 3 miles. And then I bet I can get to 5 miles, right? And improvement's kind of the same way. A lot of projects are like people trying to run a marathon without the sort of the discipline and the skills and the routines in place to do it well. And so it just takes a lot longer, or it doesn't get completed fully. And so part of that real initial stage is, how do I get into helping people get better at getting better on improvement projects, so that I can do more improvement projects and I can see results more often and faster and be able to make a bigger impact.
There's a lot that comes to mind from what you just said. You mention projects that maybe have some staying power locally, but then don't have the ability to spread well. Is that part of the work of the quality as an organizational structure consulting? When you go into a new place, you're talking to them about doing these projects better, getting better at improving at improving, getting better at getting better, but also how we take these effective frontline projects and scale them better. Is that an explicit part of the work?
It is, and it isn't part of quality as an organizational strategy for sure. It's rooted more in the basics of improvement work and spread. I mean, if you go back to the improvement guide, for example, there's after you finish an improvement project, part of your goal is to then implement it or install it. And then if it's something that should be replicated in other parts of your organization, you got to figure out how to spread it. And so I think one element that's often not included, well, there's several elements that can be embedded in the way that we do our improvement work that facilitates other objectives, right? So one might be, for example, that if we have a desire to implement, we should always be thinking about we're building towards implementation, right? So not only are we trying to improve, but we're also trying to figure out, how am I going to finally install whatever I discover at the end, right? So many times people they might be doing improvement work, but they can't connect what they did with what seems to me making an impact, and that may be part of the rigor in the end. If eventually I want to get to being able to tell you, we moved the dots on sepsis because we did these things reliably, and our data shows it. And if we were to take this to another unit, this is what would happen. This is what we would do. Or if we want to hardwire this into our unit, if we want to install it, make it permanent, and pull this team away, then these are the things that we think need to happen, and some of that becomes a new project of installation, right? So there's getting it to the degree of improvement that you want and sustaining it. The second is then installing it to make it part of business as usual, and the third is saying, well, how do I do that installation in multiple places, right? That replication. So that is an important element of quality in general. I think it's something that when I'm working with leaders to think about things that they need to improve or change in their organizations, it's one of the questions I'm going to ask is this something that happens in more than one place, that you'll always want to have a mind on how am I going to spread it and scale it, and becomes part of the thinking that has to go into the continuation of that specific project.
As you're approaching a new client, and you're some of those, a lot of organizations now will have chief quality officers, and including you, a number of people that I've interviewed for this podcast have roles of CQO or similar role. Do you notice that the structure of organizations often limits the impact that the CQO or the quality department more generally can have because of the way they're set up, and other kind of common shortcomings in the organizational structure that in theory could unlock a lot more potential in those people?
Yeah, I mean, one of the biggest learnings that I had actually when I was doing my research 7 or 8 years ago on chief quality officers is it was a little bit surprised. I was surprised to learn how the roles were defined or not defined. And actually, I still to this day remember I interviewed a great improver named Skip Stewart from Baptist Healthcare. I was interviewing him and I was telling him why I was trying to learn from him. And he had come from kind of a Deming base and came from industry. And it was really fascinating because at one point he stopped me. He said, "Oh, Dave, I should clarify. I'm not the chief quality officer. I'm the chief improvement officer." And I said, well, what does that mean? What's the difference? And he says, "Well, I improve stuff and they do all that quality stuff." And I was like, what? But what I learned as I got more into it, because I was coming from an improvement background, right? So I'd had a role as a chief quality officer and kind of in the infancy of the movement. But when my work as an advisor in healthcare and my work as a leader at IHI was in the improvement space, not necessarily in the what sometimes is defined as the quality space. So by definition, improvement is changing something to get a better result. When I started interviewing chief quality officers, I think that there were a number of things that emerged that just kind of were real revelations. And one was that almost every chief quality officer that I talked to was either the first one in their organization or they were the second one. So if you were the first one, your role and the structures were almost completely built around you. And so that it was a role that was developed, and they, if you were a physician, then maybe you got credentialing, and if you had a particular passion, maybe you got some of that stuff. It typically was built around the individual. If you were the second one, you inherited what was built for the first one, and then you were grappling with the fact that you had to try to build a system. And so actually in both cases, both first generation CQOs and second generation CQOs, they were having to either build the system from scratch and often around them and taking it to the next level, or they were building a system that was built for somebody else and now they're having to try to adjust it or fix it or sense make it for its next generation. And so that was the thing, there were a lot of common themes. Like if you pull up all the job descriptions of chief quality officers and look at systems, there's a lot of commonality. There's a lot of stuff that's similar. But then there's also a lot of stuff that's all over the place where people have, one person might have accreditation. I've run into people that are in charge of safety and emergency management. security. Like there's some weird stuff that's in there. I would say one thing that's not always consistent is that quality and improvement are together. Another thing that this came up later when I was after I designed the Chief Quality Officer program and we ran the first couple cohorts. One of the things that really stunned me was that many of the participants in the first cohort, so I think that was I think we had about 80 people that went through the first couple of years. Most of them didn't come from a background of doing results-driven improvement. And when I asked them, like, well, by what methods are you changing things? It was sort of like they'd mention it off to the side, like, oh, we've got lean, or we do some Six Sigma stuff, or and I don't know what that means. Like it was sort of like, I also subscribe to the New York Times, and like it was not like I am somebody who this is the method of which we use, and this is how we get results. They were much more experts at what are the various measures that I'm held accountable? What are the tricks and tips to try to close the minute gaps on those measures? How do I do root cause analysis? And then but when I asked them, like, well, how do you change your system going forward? The improvement side was kind of off as a side hustle, or something that wasn't as integrated. So I think that's a sign of the infancy of these structures. Now today, going on, almost 10 years after that early research, there's many more chief quality officers. And when I look at organizations, there are many that are more similar to like the one I just described to you that had an advanced training program and a shared method. There's a lot more of that kind of stuff that's happening. I still feel like there's quality and then there's everybody else. I mean, Jim Reinertsen's drawing to me of, here's my quality bubble. And then there's a bigger bubble where, people either have various theories or different ways of doing things. I think there's a lot of variation of whether quality is in those other areas or not. And I think that shifts a lot. So I think that's an opportunity. I think that, going back to what we talked about earlier, I think there's still some degree of a need, and I watch for where a chief quality officer sits in an organization. So a lot of organizations I go to, they're not in the leadership team. Like there's the chief financial officer and engagement officer and the chief medical officer and all these chief operating officer, all these people, and there may or may not be a chief quality officer, and that's probably a red flag for me. If I'm looking for where you fall in the hierarchy, if you're many times they're below the chief medical officer, that may be okay. Maybe they're blended with the chief medical officer, that may be okay. But I look for that placement. If I start going to, like more than a layer down from the ones that are on the webpage, it's probably a good sign that the structure's weak and that it's not a quality embedded as it could be. And I think that that's a place of influence, but I also think it's a place of development. So one of the reasons that we created the Chief Quality Officer program in the first place is there was no theory. Nobody had a theory. Everybody I interviewed, I'd say, well, what's your theory about how to do it? And it was all kind of like nobody's ever asked me that. Well, let me tell you what I do. And so part of what I did is developed a theory and, created a driver diagram. And a lot of it was rooted in what IHI was doing at the time. But there's a need for organizations to have a theory about how do they approach quality as a structure and across the system. And then I think there is a need for an individual who is the steward or lead of that, whether that's the chief quality officer or another C-suite person. And I think there probably needs to be a dedicated team of people whose role is to help that permeation throughout the system. They shouldn't be the ones that are relied upon to do it, but they should be helping it out there to help people at the point of care and in these microsystems do improvement work and embed it in their work and make it part of day-to-day work and leadership. But in early stages, and we talk about this in the book, many times in early maturity of an organization, they need some kind of leadership, some kind of structure in order to make quality part of the way that we do stuff. And then as you get more sophisticated, maybe you can dial that back. But I haven't seen that happen in healthcare very much.
Yeah, and I should pause to offer a debt of gratitude to you. I unknowingly was the beneficiary of your work in 2022 when I took that CQO professional development program out of the IHI. So thank you for the driver diagram and everything that you did there. I'm sure others listening will either have have gone through the program or perhaps be interested in doing it in the future. Is there anything that I haven't asked you about quality as an operational strategy that, or as an organizational strategy, sorry, that you would like to speak to?
I guess the only thing I was just thinking about this because I'm writing a paper on QoS, and as you know, if you've ever written an academic paper, like it's such a great exercise because you often have to think about how you're describing things and your argument and whatnot. And one of the questions that came back from the reviewers was like was a little sort of like, why bother with QoS? There's all these things, and it's fascinating. I recently I bought a book that was it's the study guide for one of the major quality credentials. And I was fascinated. It's actually inspired an upcoming article that I'm going to write. But when I went through it, I think there were over 25 different models mentioned in this book that quality professionals should know. And it was fascinating to me because I was familiar with most of them, but one of the things that I learned whenever I went into looking at any model, and I'll pick on one like the IHI patient safety model, or the model for improvement, or the Baldrige framework. All these are frames that each one of them was created at a particular moment in time to serve a particular purpose, and may or may not have been created with the others in mind. So they're not meant to work together. So a lot of times they were, I needed to create something because something else didn't fit. And so I created my version of things, right? IHI created the whole system quality framework because they loved the ease of explaining the Duran trilogy, but they didn't actually adopt the Duran trilogy. They created their version of it. I'm not judging. I'm just saying that a lot of these models come in that way. So one of the things that's really tough is they don't, a common problem that I used to run into and still run into when I go into organizations is people will say, well, how does this fit with that? Or how does this fit with lean? Or what about this with agile? Or what, and they're always trying to sense make, especially if they have preferences, because people will gravitate to little things that they like. And so they might grab a tool from here or they like thing. But it's sort of when you do a potluck and you've got Mediterranean and Italian and some Spanish food, right? They weren't all meant to go together. You just happened to grab all your favorite things and put them together, and now you've got this mashup. So one of the things that's a little bit unique about, I think, is unique about what we wrote about in the book and the way in which we approach things is we created a framework, one that built on the shoulders of the science of improvement. So we built on the shoulders of systems thinking and understanding variation and our theory of knowledge and psychology and human behavior, the four lenses of profound knowledge, and this real deep focus of needing design, test, implement, and spread improvement. Right. So the application of that science to fixing things, working with people who are subject matter experts in something and trying to figure out how do we change it and do projects to get better results. Right. So quality is an organizational strategy built on the shoulders of taking that, but taking it to the organizational level and to the way in which we work. And in doing that, one of the things that we focus a lot on is the integration. So we've talked a good bit about purpose. We've talked a good bit about systems. Those are parts of the activities for leaders that QoS encompasses, right? So being clear, defining and communicating a purpose is one. Two is appreciating the organization as a system, which includes having a systems view, like creating a physical map of the organization so you can see it as this interdependent linkage of processes. It includes having a vector of measures, like having a set of measures for the entire organization that are presented together, that are displayed in Schuhart charts so that you can understand variation and see how they interrelate. It involves building a system for gathering information so we can continually learn about the organization and whether the organization is fit to meet the need, or whether there's things that are happening in the world like AI or new technology or changing workforce or generational changes in our patient population that'll affect how we do things. And we bring that all together into some kind of process that helps us plan for what we need to do. What do we need to change? What do we need to design or redesign to make the place better? Or what do we need to resource and continue to operate to continue to do what we do now well? And then how do we manage improvement efforts? Right. So we plan, we identify what to work on, then we got to work on it. And that's where rigorous improvement comes in. So, I just took you through the journey of QoS. In some ways, people will say, well, that doesn't sound that different. Well, the thing that I think is unique is that it's built to work together. So there's actually an awful busy drawing that nobody likes that we include in our book that has these 5 activities. A lot of times people, when they used to make graphics, would take out all the arrows because they just want to call out these 5 components, and that makes it easy. It's kind of like the Duran trilogy. But the arrows are where the rubber meets the road, because the arrows draw the linkages and connections between these different activities. So when you're doing it, it becomes this sort of systematic approach, of which when you start, you do it at the level you're ready to go, and you get more sophisticated at it as you get better and better at doing it. And that's one of the things I think is useful. Is it's a little bit agnostic in terms of how you go about it. We have some firm beliefs. I mean, we're Deming people, and we use the model for improvement and things like that. So there's certain things that we gravitate to within it, but it's not an absolute. But the framework enables you to look at where you are, kind of get a sense of where things are, get started on working on getting better on your improvement work while you clarify the purpose and understand the system. And then it becomes these continuous learning cycles of getting better and learning more and getting more sophisticated and kind of improving your capability over time. And part of one of the questions I always get asked is, why don't more people do it? And I say, because it's hard. Like, improvement and leadership is hard, and so it doesn't work for the easy button people. If you're looking for a quick fix and whatever, there's a good chance you're not going to find one. But if you're looking for the way that you learn and the way that you get better and the way that you really kind of build up your own professional development, I can't find a better way.
Yeah, Dave. I mean, I think so many people will relate to this feeling of having different frameworks that can be applied with different levels of rigor and like you say, not well integrated into, not designed to work well with each other. And so the idea that this would bring some of those together and make it, easier to apply, easier to kind of create weave into the DNA of your organization sounds like something I could really take a bite out of. I'm really excited actually to finally get a chance to read your book. I want to thank you so much for your time today. We went a little bit over time, but I really enjoyed learning more about what you're doing and how this fits into the broader landscape of quality improvement. For listeners who would like to follow your work or connect, what's the best place for them to do that?
Well, the easiest way, I mean, obviously the books are available. I always encourage people to start with the Quality as an Organizational Strategy book. And then if you want to go further, you can think about the QoS Field Guide. Those are available at your favorite booksellers. My website, davidmwilliamsphd.com, is where I write pretty regularly and post things, both to my newsletter and to my blog that people are going to. And then actually in April, I'm going to have an open program for leaders that are interested in thinking about their organization through the quality as an organizational strategy lens. And I'm going to share information about that on my website and on LinkedIn and other things. And I always encourage people to connect with me on LinkedIn too. You can find me at David M. Williams, PhD. And I love just learning from people and making connections there. So that's probably the easiest way. And thank you for inviting me to be part of this conversation. And I appreciate getting to chat with you and share with your audience and your community.
Yeah, likewise, the pleasure was all mine. And I will make sure to include those different links to your website and to the LinkedIn and other resources we've mentioned in the podcast today in the show notes. Again, thanks so much for an insightful view into quality as an organizational strategy, both the book and kind of this broader set of ideas that you and your co-authors have been cultivating for so long. Thanks so much for the conversation. I look forward to seeing you again. Thanks so much for listening to today's episode of Leading Quality. If you enjoyed the show, please take a moment to like, subscribe, and share it with someone who might find it useful. You can find all our episodes at leadingquality.buzzsprout.com or in your favorite podcast app. The show was written and hosted by me, Jason Meadows, edited by Milan Milosavljevic, and produced by Thrive Healthcare Improvement. See you next time.